Well, good afternoon, everyone. Sorry for the delay. I want to introduce two people from UVM Medicine Hospital, Dr. Heidi Haapala and Dayna Ryan. I'm going to talk about pain in adults with cerebral palsy. I know it's cold out and our emotions tend to take it out. So I thought it would be a great topic to start the new year off. I'm going to let the two of you present. Please let me know if you need anything.
Okay, thank you. Thanks, Paul. Hi, I'm Heidi Haapala. I'm an adult physiatrist at the University of Michigan, and Dayna Ryan is a physical therapist there. And I'm going to start off the talk, and then she'll pick up after I talk about the medical parts to go over therapies. I see adults with cerebral palsy at the University of Michigan in the physical medicine and rehabilitation department. And both of us get to see a lot of people with pain. And it's, something that's so common in adults with cerebral palsy. And we're still learning a lot about how to deal with it. So let's see if so today, some of our objectives is to talk about how pain phenotypes can aid in assessment and treatment of pain. And then identify strategies for treating pain based on what type of pain is present. And then identify at least 2 strategies that could try to prevent the onset or worsening of pain symptoms. And some of these words may be bigger words, but we'll go over some of the definitions as we go along. So in my part, I'm going to be talking about clinical approaches to the management of pain. So as we know, pain is very common in adults with CP, and there's been quite a bit of literature talking about pain in both children and adults with CP. And there's several different studies looking at prevalence, but one of the studies is done by Vandersloot and has described approximately 70% of adults with CP have pain. The most common, and they do talk about locations, and most common were the legs, the back of the neck, and the arms. And what I want to talk about is pain phenotypes, because most of what has been done in studying pain is looking just at where is the pain and talking about like musculoskeletal pain. So phenotype is just saying, looking at the type of pain and using that's the word that we use to describe this. So here is a diagram we'll go back to, but just before we start going over these phenotypes, this is sort of the 3 types of pain that we look at. There's nociceptive, neuropathic, and nocipathic, and we'll go over all the definitions in just a minute. But the one thing I want you to get out of this slide is that these pain types do not have to be present in isolation. You can have more than one type of pain at the same time. And that can make things more difficult to evaluate and treat. And it's really important to understand that you could have more than one type of pain, and that can affect your treatment plan. So nociceptive pain is the pain, like if we're looking at the definition, is from tissue damage. So this is where most of us who think about pain, this is the type of pain we think about. And this has been the focus of most of our research in pain with cerebral palsy. Descriptors of this pain would be like achy, sharp, dull, and it's usually localized to an area that has been injured. Musculoskeletal pain, like pain from arthritis, pain from tendon injuries, soft tissue injuries, soft tissue sprains, strains, all of those could be examples of nociceptive pain. Another common cause of nociceptive pain is pain from a broken bone or pain after surgery. The other type of pain that has been pretty well recognized, but may not be thought about as often, is neuropathic pain. So this is pain from nerve damage. So somatosensory is the nervous system. So when nerves have been damaged, we often hear words like burning, tingling, hypersensitivity, hot, cold. And when we're looking at this, we need to do like a very careful neurologic examination. And sometimes we'll see that there's sensory changes where something has numbness or loss of sensation or weakness. Common examples of neuropathic pain are a radiculopathy or a pinched nerve, like in your neck or your back. Peripheral neuropathy, like someone who has diabetes and nerve damage from that, or nerve entrapments like carpal tunnel syndrome. The third type of pain is nocipathic pain, and this is a much newer type of pain that has been recognized. The term was just proposed in 2016 in the research literature. So there's still a long way to go with understanding this terminology and recognizing it. And this is the type of pain used to that's describing pain that's not due to muscle or nerve injury. Prior to the term nocipathic pain, people had called it centralized pain. And the definition by the IASP, which is the International Association for Pain, says the pain that arises from altered nociception, or that sensing of pain, despite having no clear evidence of actual tissue damage. So it's a pain that is present even if we can't figure out why it's there. So with nocipathic pain, there's a pretty classic symptoms where you have pain in multiple parts of the body, or what we call widespread pain, plus somatic symptoms. And somatic symptoms are things like fatigue, memory problems, mood disorders, abdominal pain, or difficulties with sleep. So some types of pain that are considered examples in this category is chronic widespread pain, or something like that's called fibromyalgia, chronic back pain, chronic migraines, and then chronic visceral pain, or something like irritable bowel syndrome or interstitial cystitis, if you've heard of those terms. So it can be all these pains in different parts of the body and affecting different systems. And the one thing that's really important, and if you think back to the diagram of the 3 overlapping circles, just because somebody has a component of nocipathic pain doesn't mean that there isn't a pain issue in the body, that there's some other like musculoskeletal or neurologic problem also. So we can have this overlap. In nocipathic pain, the pain is maintained in the central nervous system, but the peripheral pain generators, so something like arthritis or nerve pain, can contribute to the ongoing pain. So they sort of feed on one another. It's really important to recognize this or understand that there's other types of pain present because we treat it differently. This is a scale that some doctor's offices or research labs use for evaluating pain and deciding if there's a nocipathic component. So again, you see here the body map with multiple areas, and if you fill this out, you check out which areas have been painful in the last week. So if you end up having shoulder pain, back pain, headaches, we start getting multiple check boxes here. And then we look over here for the somatic symptoms, and you rate this from no problem with pain to, or no problem with these symptoms, to a severe problem. And this is, all these boxes are counted up and you're given a score. And the higher the score, the higher chance there is some overlap of nocipathic symptoms in your pain experience. So once we've talked about understanding types of pain, what do we do with it? So how do we assess pain? First of all, I want to make sure that when we're talking about assessing pain, CP getting worse is not a diagnosis. I have had a lot of patients come to me sometimes and they say, well, I'm just probably getting old and I think my CP is getting worse. So some things can present with worsening over time, but it's still usually caused by something. So that's an important thing to think about. And I just want to point that out. There could be some other, muscle problem, joint problem, arthritis going on that is making people have more difficulty with pain or function. So back to this overlapping circles again, just to keep this in mind as we go through the next section when we're talking about assessing and looking for pain. Here's some examples of the nociceptive pain, the post-surgical pain, the tendinitis, the arthritis. And if you see here, these bubbles can overlap. They don't have, so osteoarthritis could have just only the nociceptive, but it could overlap where we have a couple different types of pain causing it. And if we think that's going on, just treating arthritis with our typical treatments for arthritis may not be as helpful as adding in some treatments for nocipathic pain. So when we're assessing pain or fatigue, so sometimes it's hard to differentiate between pain and fatigue. So sometimes we'll talk about them together and sometimes separately. It's really important that we get a good history. Like when somebody comes to my office, we try to take a really careful history and do a physical exam focused to figure out if there's any new neurologic changes, any changes in function that can give us a clue of where to look for these. Check if there's any medical conditions that are causing the problem. And then when we talk about the pain, asking about the quality of the pain, again, is it achy? Is it sharp? Is it dull? Is it burning? Those type of things can help with understanding where the pain is coming from. And is the pain or fatigue related to muscle weakness, overexertion, other medical conditions? And the other things we try to ask about, are there other issues with sleep, pain in other body areas, any mood problems? And then when we're looking at treatment, when we're looking at pain or chronic pain and fatigue, it's really important to think of this as multiple options for pain. So we have this multimodal approach, and we like to do it stepwise with like the least invasive treatments first and step up the intensity as we go along. The goal when we're treating pain is to focus on function and maintaining function and maintaining participation in daily activities. We want to target the treatments to address the underlying mechanisms. And we really want to work on improving strength and improving biomechanics to take the stress off the joints and work on encouraging activities that can be performed without worsening joint alignments or worsening spasticity. We also want to limit activities where there's too much energy spent to do it, or you're doing activities where you're not in good alignment and the joints or the spine get excess stress on them. So over the next couple slides, we'll go over like medications, procedures, therapies, and alternative treatments that we could look at. So some of the things that you may have heard of or experienced in the past, and that we will look at when you're looking at treatment options are orthotics, therapies, and some equipment things. Orthotics often works best, I find, when we work in conjunction with a physical therapist. Many of my patients have tried orthotics, and for some reason or another, they haven't worked well, or they're too cumbersome or bulky. And it's hard to figure out like what's the best improvement in function that's going to be easiest to use in your daily life. Therapies can include when you go to therapy, the therapist can talk to you about adaptive equipment, energy conservation, joint protection, strengthening, and especially a home exercise program. Equipment things that we will look at oftentimes would be assistive devices like a cane, crutches, walkers, wheelchairs. Often it's really hard if I have a patient who's come in who hasn't used a wheelchair in the past, but it may benefit. And we talk about that. That's often over many visits because that's often a huge change in lifestyle. And some of the reasons to consider assistive devices or things like wheelchairs is for energy conservation or protecting the joints from extra damage. So for physical therapy, I'm just going to briefly touch on this as Dayna can go over this more. But the type of physical therapy really depends on the issue you want to address. There's manual or musculoskeletal focused PT for focused like arthritis or single joint problems, or there's neurorehabilitation that focuses more on understanding the cerebral palsy and the spasticity and the muscle control. And that can often be a very helpful type of therapy. Therapy will benefit if I, as a physician, can give a very targeted diagnosis and some specific treatment recommendations, so the therapist and the patient both know what they want to work on. And the other really difficult thing is that insurance coverage is different for adults. So many times as children, my patients have had multiple rounds of therapy. And as adults, there's usually problem focused, where the insurance will allow for like a new issue. And then you have to, as soon as you plateau or don't make any more progress, or you have had a certain number of sessions, the insurance may say that's enough. Now you need to manage it on your own. So therapy looks different for adults than it does in children. Occupational therapy can be really helpful. And this is not always done as often in adults, but it can be helpful if we're trying to retrain like ADLs, which is activities of daily living, like dressing, bathing, working on arm function, hand function. The OT is also good about educating about energy conservation, pacing, and posture. They're the ones you could talk to about your home or work environment, and think about adaptive equipment to make some of those daily activities, like your dressing, bathing, meal preparation, easier. And some of the other, when we're looking at treatments, such as medications, procedures, or alternative therapies, one of the things that's really important, and this is where we get into those pain phenotypes that we went over earlier, is that medications for pain are different depending on the pain phenotype. So if we have nociceptive pain, NSAIDs like ibuprofen or leaves, things like that work, or naproxen work well for musculoskeletal pain, or even acetaminophen, which the brand name would be Tylenol. Neuropathic pain or pain from nerve damage, gabapentinoids, so like gabapentin or Lyrica, sometimes tricyclic meds, although those meds have so many side effects, we rarely use them anymore. Those can be helpful for nerve-related pain. Nocipathic pain, there's a different type of medications that we use, and some of these medications were originally developed for other conditions like nerve pain or mood disorders. So cyclobenzaprine or Flexeril is sometimes helpful. Duloxetine is another common one that we use, and then gabapentin or pregabalin. And importantly, we do not recommend opioids for nocipathic pain. And we'll go over that a little more in the next slide. Procedures that can be done for pain. You can get joint injections, spine injections, botulinum toxin injections. There are surgeries that are done, less so in adults than in children, but sometimes surgeries are done. Surgeries for like baclofen pumps would be one for spasticity treatment. If we're doing procedures, it's really important ahead of time to set the goals of treatment so we know if what we're doing is helping and if we should continue or not. And it's important to use caution if that centralized pain or that nocipathic pain scale is high, because often some of these focus treatments don't work as well until we sort of taken and decrease some of that overall body pain. Some alternative therapies would include self-management, whole health, meditation, yoga, tai chi, and acupuncture. These can be very helpful for some people. It's hard to tell until somebody tries them which ones would work better than others. Some work better than others, and it's very individual. And here is the really important part that I think is important is like opioid medications. So opioid medications are often used. So that is your like morphine medications, hydrocodone, oxycodone. Those are often used for pain. But it's very important to understand that depending on the type of pain, it may not help that much, and sometimes it's worse. So for nociceptive pain, there have been studies that showed when they looked at giving somebody an opioid versus giving somebody Tylenol or ibuprofen type medications with musculoskeletal pain, there was no difference in the pain control in acute pain or chronic pain with those, with NSAIDs, acetaminophen versus opioids. So if the NSAIDs and the acetaminophen work well, we do not recommend giving a medication that is going to have a lot more side effects. For nerve pain, the first line agents are those SNRIs, or those antidepressant medications such as duloxetine. The gabapentin type medications are first line, and opioids are not in the first line treatment. They're potentially way down, if at all. And nocipathic pain, and here's the one that's really important, is nocipathic pain, opioids are not helpful. And studies show no improvement in pain and likely some worsening in pain overall. So that is a part where it's very important to understand that we might actually be making things worse with giving opioids. And the question is, why do I bring this up? Well, this is why. This is a study that we've done at the University of Michigan. My colleagues have looked at, and we've looked at the opioid prescription patterns. And this is a group that we have looking at data from medical databases. And this is looking at the prescription patterns in people with CP and spina bifida. So this database that we have has both. And then there's controls. So the important part here is, here's the bottom line. At the bottom of the graph is the people who did not have CP or spina bifida and the amount of opioids they got, which is very, very low, close to zero in the past year. Then there's a few other bars that say isolated, like just one pain complaint in the last year or multiple pain complaints. And it compares cases and controls. They're all kind of in this little bit higher range. This top line is the one that's really important. This is the amount of opioids given to people with cerebral palsy or spina bifida with multiple pain types. And it is, this line, if we look at the actual numbers, is nearly twice that of all of the others. So if you don't have CP and you have multiple pain types, you're here around the 8,000 average per the course of a year. And over here, it's anywhere from 13 to 16,000 equivalents. So they just count up the morphine equivalents and get this number. But the important part is to realize that people with cerebral palsy or spina bifida are getting prescribed opioids at a rate nearly twice that of somebody who does not have that diagnosis and still has multiple areas of pain. And the problem is that these medications have complications, as we all know, with the opioid crisis. And and for my patients specifically, we can have problems with mixing with other medications, because we know that opioids mixed with certain types of spasticity medications can make you more sleepy and cause problems with breathing. Mixing with Valium or those type of medications is known to be very risky, or even the gabapentin type medications can all cause more problems with sleepiness and difficulty breathing. So we get very concerned when we look at this graph. So now I'm going to turn it over to Dayna for talking about physical therapy and pain.
Thanks. As Dr. Haapala said, my name is Dayna Ryan, and I'm a physical therapist and neuroclinical specialist, and I work at the University of Michigan as well. Might advance in the next slide. Thanks. Yep. Okay. So some common reasons why people with cerebral palsy will come to me for pain. Usually it's spasticity, and it's it's not controlled, or it's acutely increased, or they have an orthopedic issue. The main ones that I see are osteoarthritis in the low back, hips, knees, and ankles. So all of your weight-bearing joints. Joint pain in the non-spastic side from overuse. So say you have cerebral palsy and your right leg is more spastic than your left. You'll see overuse injuries because they're standing on the non-spastic leg 99% more than the spastic side. There is maybe because there's a structural leg length discrepancy. We see this a lot more in people with cerebral palsy because they have had spasticity acting on their bones and muscles and joints since they were babies. So the limbs just don't grow the same if they're not being weight bared through the same. So, but a long life, many decades of walking on legs that are different lengths can have pain implications. And then scoliosis or other spine issues. For the same reason, spasticity is acting on their body their entire life, and it's back when their bones are still soft and developing, and this can cause a variety of spinal deformities that lead to pain as adults. Next slide, please. So how pain from spasticity can be treated in general. Just to review some of what Dr. Haapala said, there's medication, botulinum toxin injections, or things like ITB, baclofen pumps. Or we can teach them a stretching program in physical therapy, teach them how to get their weak muscles strong, because what I end up teaching a lot of my patients is that spasticity is not strength. It's a volitional muscle contraction that is actually your strength. But people with cerebral palsy get so good at turning on their spasticity that they're actually able to activate their tone or hypertonicity, their spasticity, and they think it's strength when really it's a reflex. And then use of a functional electrical stimulation is a tool that I have come to use a lot more in recent years since I've learned how well it works. Next slide. So first, let's talk about how we might improve that orthopedic sources of pain, or the nociceptive pain that Dr. Haapala referenced earlier. We need to strengthen the weak muscles, and you might not even realize the muscles are weak because maybe you're still walking, or they look visually developed, but maybe they look visually developed because of how you're standing or how your spine is curved wrong in one place, or too much in one place, or not enough in another. Stretching your tight muscles or your spastic muscles is really important. So just in somebody without spasticity, a really popular source of low back pain, for example, is tight hamstrings and hip flexors, just from like being tight, from not being active just normally. Unfortunately, in cerebral palsy, the most commonly spastic muscles are plantar flexors, your hamstrings, and your hip flexors. So though they'd be even more likely to acquire mechanical low back pain. Functional electrical stimulation is a really effective tool to teach muscles how to contract how and when they're supposed to contract. So it's a very common tool to strengthen appropriate muscles when doing functional activities. Likewise, use of functional electrical stimulation can also be used to help suppress spasticity by changing settings slightly. But that allowing spasticity to be knocked out, so you can't activate it when you want to, even reflexively when you don't intend to, actually allows for better strengthening after the fact of the muscles we want to strengthen. I teach a lot of body mechanics as well. Unlike somebody that maybe has a spinal cord injury or a stroke, they walked as humans, bipedal humans are biomechanically intended to walk for a portion of their life. Unfortunately, with cerebral palsy, that never happened. They've had this their entire life, so they've just learned to get by, to get from point A to point B on their feet. And they didn't know, oh, I was supposed to stand this way, activate this muscle this way. And so I take it back to, let's just try to see if we can learn better body mechanics to prevent further abnormal wear and tear on our joints. And that is incredibly common in all of our weight-bearing joints, like the low back, knees, hips, feet, and ankles, most commonly. And then I use a lot of orthotics to correct joint position, to make it easier to coordinate. So if somebody walks, whenever they meet me, a common comment I get from patients is, I didn't understand walking was so complicated, because it is truly difficult to coordinate when done like as it's biomechanically as we are biomechanically intended. So if I can get somebody a brace for their ankle, so they don't have to worry about coordinating that joint, that they can just work on their hips, their knees, that works sometimes really quite well. Also, using an assistive device can help just take some of the pressure off of a joint by taking it up through your arms and improving your balance. If your body's not having to work so hard to balance, it can help. Next slide, please. And so I would be remiss to avoid if I avoided talking about wheelchair assessments. So just having a conversation about wheelchairs alone is difficult. And just because you get assessed for a wheelchair doesn't mean Dr. Haapala or I intend for you to start using it right this moment, all the time, 24/7. It takes a really long time to get medical equipment. And so if you're starting to have very limiting pain that stops somebody from functioning, like from going out to take their kids to the zoo or going to an amusement park, we want them to still get to participate in life. And because that's a quality of life issue, but it takes almost a year to get a custom wheelchair if everything goes according to plan, like with insurance coverage and everything. So starting that process soon, and then you guys have it, is a lot of times what we're thinking about from a clinical standpoint. Also, if you're a person who 90% of your time, you're just walking a little bit through your house, that's fine. But once a week, you go to the grocery store and walk for an hour, and you are in so much pain afterwards that it affects your ability to function that night and the next day. That might be where we start thinking about, okay, could you use the wheelchair for that day or for that grocery store trip? And then you're okay the rest of your week, just to avoid abnormal wear and tear on the joints. That excessive wear and tear on the joints is where, as clinicians, what we're looking at. So we don't want to just get you any old wheelchair though, because a sling bottom, sling back wheelchair that you buy on Amazon for very cheap could cause problems as well. So we like to try to look for optimal seating and positioning. It helps control, if we do it right, it can help minimize your spasticity with prolonged sitting, improve your posture, and just improving your posture alone can help with back pain. It can also cause joint pain in general if your knees are stuck in too bent of a position or too straight of a position. It could cause skin breakdown, and it could actually worsen your spasticity and contractures if you're uncomfortable, because pain increases spasticity because you're uncomfortable, and it's a reflex that you can't control when you have cerebral palsy. So if we can provide as much comfort as possible, that helps the symptoms of our patients. Next slide, please. And then another thing I talk about with people is the importance of doing a general exercise and strengthening program in general. Like you get so much benefit from exercise, more than just strengthening. It's good for cardiovascular health. There's benefits for just endorphins when you exercise to improve your mood. And joints hurt more when they're not moved. So how can I help people exercise in a way that won't cause them pain, that won't stress their joints, and allow all of these other great benefits of exercise? Because what we see, what Dr. Haapala and I have seen in research that we do here more than anything, is that there's all sorts of secondary health issues that happen in general for people that have a sedentary lifestyle, like cardiovascular disease, diabetes. So if we can help prevent, like cerebral palsy is enough. If we can help prevent some of these other secondary issues, your quality of life for longer of life will be better. Next slide. So this leads into why is addressing pain so important for this patient population? It improves quality of life, plain and simple. Spasticity increases in response to increased pain symptoms, and we want to minimize the spasticity because increased spasticity causes pain in itself. So it's this vicious cycle of pain and spasticity, but also too much spasticity makes you wear your joints wrong. And so it accelerates the onset of osteoarthritis in adults with cerebral palsy. So if we can keep your spasticity lower, that will help prevent abnormal joint wear and tear more than it's going to happen anyway for people as they get older. And then as people have pain, they change the way they move to try to avoid said pain. And so then they acquire these new abnormal movement patterns that could actually cause more pain down the road. So I like when they see me sooner, so we can change these movement patterns before they come into like very strong habits. Next slide. So Dr. Haapala and I thought it would be maybe helpful for everybody. We wanted to share a few patient case scenarios that cover all these concepts that we've talked about today. And they're patients that both Dr. Haapala and I have shared over the years. So if you guys have any questions, we can generally answer them. But the first patient, he was a 60-year-old male with cerebral palsy, and he came in reporting pain everywhere. He was sent to me. So Dr. Haapala saw him, he was sent to me, and he was just, every time he came in, he couldn't exercise. He never did his home exercises. He was depressed. And then being in too much pain to do his home exercises made him more depressed. Made him lose motivation to do anything active, which then made him become more stiff, more spastic, and have even more pain. But he was convinced when we met him that the only medication that worked for him was OxyContin, and that we were all messed up for not understanding him, and we just needed to give him more. And Dr. Haapala tried gabapentin with him instead of that, and that actually took care of his pain instead of just making him too high on opioids where he didn't feel much of anything, including the pain. And he now has, so he had so much nerve pain that the gabapentin lowered the nerve pain. He is now able to exercise daily. With the home exercises I've taught him without issue. He's now more fit. He has much more positive attitude on life. He's gone back to work. He's been able to resume work. And so, yeah, did I miss anything?
I don't think so. I think the important part is like when pain is out of control, like you said, it affects your sleep, it affects your mood, all of it gets all jumbled together and it all feeds on itself and becomes just so complicated and so overwhelming. And it's really hard to take that step to do anything when you're in chronic pain. And I see other patients too with chronic pain without cerebral palsy. And this is common for anybody with chronic pain. It's just overwhelming and you don't know where to start. And if we can chip away at one little thing at a time, like changing a medication where it can help that overall, just calm down the overall pain and start chipping away, then you can sleep better. And when your sleep is better, you feel better. And when your sleep is better, that's also when you can heal some of these other issues and you have more energy to exercise the next day. So it's just taking these little changes and slowly making changes over time where we can it doesn't happen overnight most of the time too. Like these are like conversations and multiple visits where we need to kind of figure out like, what is the biggest problem? What do we address first? What do we address second?
Yeah, exactly. So the next patient case is a 58-year-old female with cerebral palsy. She had an incredibly active life in her teens, early 20s. She was actually in the military. But by the time I met her, her hip pain had become unbearable. It was difficult to walk, keep up with her friends and family. It was limiting her participation in the things she wanted to do. So she came and we first started with electrical stim to help lower her spasticity and pain to start, so we could work to strengthen out of these pain patterns, learn how to walk the way we're biomechanically more meant to. So she was avoiding more wear and tear. As she got stronger, she was better able to do that, manage her pain. And now she participates. She does functional electrical stimulation at home in addition to stretching and exercises. And it's a routine that she enjoys. She can do aerobic exercise without the old, like, I remember with her, it was running. She really wanted to run, but the way she was running was damaging her joints. So she was really receptive to, okay, well, let me try biking. That's a much less weight-bearing, joint, like crushing activity. And she's just doing great. And then, did you have anything else to add? Okay, so case number 3.
I didn't have anything for that. Yeah, I think it's just, again, different treatments for different problems. And again, stepwise, like if doing therapy works, then we can just maintain that and not have to go further down the path of adding other things.
Yeah, and it's been a great, like Dr. Haapala and I have been a great collaboration, like, hey, this person is experiencing this now. Oh, can we work on this? Like, it's been great
Yeah,
to,
a lot of these are much
Right.
more, everything is more complicated than we can give with in simple cases, and we don't want to, we keep it
bog you down.
broad, so it's not too
Right.
specific.
Right. And then the next patient is a 39-year-old female with cerebral palsy. She had a job that required her to walk really long distances every day, but she loved her job. But she was coming to physical therapy. She was referred to me from Dr. Haapala because her low back and hip pain became too limiting to walk at all on her non-spastic limb because from overuse, she was always standing on that side. So after participation in PT for some strengthening and stretching, she found some improvements, but the most pain relief she received was switching to use of an assisted device at work when she could, and then using a wheelchair for longer distances. So she's now still able to work full time.
Yeah, and I think this case could be a conglomeration of multiple patients where we can just use an assisted device for that energy conservation and joint protection. And still be able to walk in most of your daily around the home and most daily activities, but for those longer time periods, the wheelchair can be helpful. And I've seen this with college students also. We can work on that. And it's just able to just be so much more engaged in school because you're not exhausted from trying to walk across a campus.
Or you're not late to class.
Right.
Right, so yeah. So next steps for you guys, we would recommend you first find a physical medicine and rehabilitation physiatrist like Dr. Haapala or her colleagues, or find a physical therapist who specializes in neurology. It doesn't have to be me, my colleagues also, but also clinics in general. The most of the physical therapy clinics that you see in strip malls and such, they're orthopedic clinics, and they have their purpose. Unfortunately, it isn't for the adult with cerebral palsy. You really need somebody who will understand spasticity, and that will happen only in physical therapists that specialize in neurology. They will also have the ability then, because they understand your spasticity, to be able to teach you individualized stretches and strengthening exercises. They'll be familiar with concepts like functional electrical stimulation, and they'll way more likely to have equipment that you can trial, like canes, walkers, or orthotics like ankle foot orthoses, or maybe just adding in a heel lift or an arch support, but they're more likely to have those than your standard orthopedic clinic.
Yeah, and I found that when I've sent people further away, looking for the neuro rehabilitation, so neurological rehabilitation affiliated with a hospital often works well because then they have access to some of those bigger pieces of equipment that could be helpful and access to like an orthotics department. And the therapists get to see, they work with patients who've had strokes, spinal cord injuries, or brain injuries. And so they're very used to dealing with neurological issues such as spasticity and using orthotics.
And they usually are staffed because they're associated with the hospital to treat patients one-on-one. Unfortunately, some of these like smaller orthopedic clinics are very it's much more profit focused, and you get a physical therapist to evaluate you, and then you work with somebody else the rest of the time, and their attention is divided between multiple patients, so they're not going to see the compensations as well as somebody that you get to work with one-on-one.
So I think in summary, one of the biggest things that we want you to know is like CP getting worse is not a diagnosis. There's usually something that's causing symptoms to worsen. And assessing pain and function requires really careful history and exam, especially focused neurologic and neuromuscular exam. And again, like a stepwise approach, multidisciplinary. So like I work a lot with Dayna, occupational therapists, orthotists, and other allied health people to work on getting people the right resources. And then just be aware, like we went through all those fancy like pain phenotypes, but just being aware that nocipathic pain is something that we're learning more and more about. And people might have been diagnosed with fibromyalgia, and that's one of those conditions. And just knowing that and realizing that that can affect what medications are helpful and what interventions may be more useful is important. I mean, we still could have underlying musculoskeletal issues that require attention. And I think that's where I showed that picture with the overlapping circles is so important. Just because somebody has a diagnosis of fibromyalgia or a chronic nocipathic type of pain doesn't mean we don't address the musculoskeletal problems. But we also can't just address we have to address both. And again, it's going to take time and kind of piecemealing through things. Energy conservation and joint protection is important for management of pain and preserving function as individuals age. And finding neurologically trained therapists, as we just discussed, can really help to maximize outcomes. So thanks for your time, and any questions?
Paul, you're muted still.
I see one in the chat about
Yeah.
a therapeutic massage.
Yes.
I don't know, Dana, what you think. Some of my patients have found it helpful. I think the biggest problem is that it costs a lot of money and it's usually not covered by insurance. So it's one of those things that people find helpful, but it's very temporary. So it's an expensive option, but for some people they found like if they get a massage maybe once a month, that keeps things under control. So it's one of those that we don't have a strong recommendation, like that you need to do it or that you shouldn't do it. I think if you find it helpful, it can be helpful, but it's just hard because it's not covered by insurance.
Yeah, well, usually the patients I have that like find therapeutic massage to help with their pain are the ones who have pain because of overuse of their non-spastic side. But therapeutic massage doesn't really help a ton with spasticity. And then is there a database of neuro PTs for those without access to a university? I do not believe so. Unfortunately, there are only 90 certified neuroclinical specialists in the state of Michigan. The American Physical Therapy Association, APTA, has a website that they may have organized a database. Last I looked, I got certified 5 years ago, and their database didn't exist back then. But maybe now. I can look into that maybe and email Paul. Would that be an option for you to send out to everybody?
Yeah.
And
Okay.
I think the other things that I have done is just look for neurological rehabilitation. And if you see on the website that they have physical therapist, occupational therapy, speech therapy, all at the same facility, that's a good clue that you probably do have a neuro rehab facility. Even if the therapists aren't specialty certified, they may have a lot of experience.
Yeah, I think that's a great tip.
And you can also look for, we treat stroke or spinal cord injury. That's another good clue. And then calling a few places near you and asking if they have specialized neuro rehabilitation therapists.
Andrea, did you have a question?
Yeah, can you hear me?
Yes.
Yep.
Heidi, we're part of the U of M network. Can we just go through and request an appointment with you or go through our doctor? What would you recommend?
I think that they usually recommend a referral. You can always call the call center at the PM&R department and ask if they'll take a self-referral, or if you need a referral, it'll depend on your insurance.
Okay.
And there's a couple of us that see adults there, myself and Dr. Schmidt. And then Dr. Hurwitz is our department chair, who's an outgoing department chair. So he may have some more adult clinics, but he's also has other duties. So it probably would be one of us.
Okay. What is the clinic called?
It's in the Department of Physical Medicine and Rehabilitation.
Okay. Thank you.
So so there's somebody asking, how can we obtain a copy? I don't know if this is going to be available online, but
Yes,
is sleep
it will
disorders.
It will be on our agency website and on our YouTube channel.
Okay. So there, you can see it again. And then you
Yeah.
can see the slides there too. Is sleep disorder common? Yeah, yep. It is one of those things when you don't, when you have a lot of pain, it's hard to sleep. And when you can't sleep, your pain gets worse. So it's common, yes. And sometimes we start with the pain, sometimes we try to address the sleep. It really depends. But we do try to work on just good sleep hygiene, like trying to get to bed at a certain time. Right now, one of the biggest problems is we all have these tablets and devices that, have the blue light and probably affect our sleep too. So often I recommend, staying away from devices for a couple hours before bed. There's some simple things that can help a little bit, but sometimes also just talking to your primary care to see if there's any other sleep disorders could be helpful.
So I did this wrong. The question about the NeuroPT's database, I did find the database and I have a hyperlink. How can I
There's a type answer here, so I think you can put it in.
I see. So that is so that I included it, but it won't let me make it a hyperlink. So did that get received in the answer? Oh, it made it a hyperlink in the answer. Okay, excellent. That's the database, and you would select neurologic as the specifics, but you need to put in like your own address, and so it can search near you.
Thank you both. Thank you for your time and the information. I really appreciate that. And that's UCP CP task will be on March 25th, which is also CP Awareness Day. So stay tuned for that.
Great. So any other questions? I think we've got it.
Thank
Awesome.
you.
Thanks for having
Great.
us.
Yeah, thanks for having us.